Okay, thank you, Joachim, dear Chairman, dear colleagues, dear Felix. Thanks again for inviting me and being part of this year's Lange Symposium. And thank you, Amzan, for your nice introduction. You really paved the way, because much of what I'm telling you right now is nothing but the translation of this pathophysiology into the clinic. So the background of my talk, I think, is already known to you, that the incidence of childhood cardiomyopathy is about 1 in 100,000 children. Dilative cardiomyopathy is the most frequent form and the prevailing course for cardiac transplantation in these patients. I'm just touching briefly on other forms of cardiomyopathy, restrictive cardiomyopathy, toxic cardiomyopathy, ischemic cardiomyopathy, and other forms in childhood. And it's a gloomy prognosis because survival at 5 years without transplantation is poor in this patient group. On the other hand, we recently pulled together our 30 years transplant experience in children with cardiomyopathy. Although we see that there is an increase in prognosis of these patients over the decades, and survival in the entire group and the group with dilated cardiomyopathy is about 75% at 30 years. We all know that this is exchange of one disease for another disease. It's not cure. There's morbidity and mortality both on the waiting list, on the assist device, and after transplant itself. So that for us is a motivation and really an obligation to, as strong as we can, look for alternative concepts to avoid or at least postpone transplantation in these children. After medical stabilization of a patient, and I don't talk about medicine at all in this talk, although it's a very important topic on its own, the first thing we are considering is the decompression of the left ventricle by transeptal puncture of the atrium. Now, in the adult population, it become quite en vogue now to talk about HFpEF, restrictive cardiomyopathy in childhood, maybe an analogous component to that, where systolic function is well preserved, but the atria are congested. And particularly in those patients where we don't manage to get them off symptoms of congestion, of pulmonary congestion, that we don't manage to wean off diuretics, we strongly consider transeptal puncture and balloon dilatation of the atrium. And we know from the adult data that left atrial pressure increase and enlargement is the major cause for hospitalization in the adult group. With reduction of left atrial pressure transfers directly into outcome and prognosis. And we also know from a historical group of Lutenbacher's patient, rare disease, where there's combination of mitral stenosis with ASD, that these patients do better under exercise, have better long-term prognosis, and that's most likely because they have a pop-off at atrial level. So technically, that's very simple. And Anna Bauer, in a nice MD thesis, put together the data of the last 50 patients that underwent atrial decompression, either in Frankfurt or Gießen. And she could nicely show that compared to baseline levels immediately after atrial decompression, the pressure not only drops, but the same is true for BNP, and the effect is the more pronounced, the larger the pressure drop of the left atrial is. Second thing that I want to touch briefly on, because this is also crucially important, is patients with dilative cardiomyopathy and left bundle branch block. You can see here a child where a complete left bundle branch block is associated with severe dilatation of the left ventricle. Child was sent for cardiac transplant, heavily congested, and in this patient, you see here again, left atrial decompression was done in this case with a stent. With a CRT system, you have the chance to postpone or prevent transplantation. It's an exquisite group on its own. And this is pictures from Dr. Gonzalez, who runs our EP outpatient clinic. The patient at follow-up with, oh, sorry, can I go back? Can you play this again for me? This is the patient. Can you click on the? Oh, okay. I do that way. And force again. Okay, thanks. So that's a patient with cardiac synchronization, and if you turn off the synchronization in the outpatient clinic, you can see that there is again failing crosstalk, failing interaction between the two chambers. And this is another patient, again the same thing, a complete left bundle branch block, severely reduced function, synchronization was done, nicely working after 6 years, and then this patient was doing fine. We didn't see him for another 3 years when he turned back to our outpatient department, because the local physician looking after him noticed that the left ventricle was dilating again, becoming bigger and as well contractive. And the reason I'm bringing this up is to make the point that when embarking on this is a lifelong endeavor. You have to carefully look after the children, and what's happening here is the first thing is the child was not increased on the doses of beta blockers that he was on, had the same dose as on discharge from our clinic, and the second thing is that the atrial lead was going to be less well sensing. So you see that here is an acceleration of heart rhythm with a breakthrough of the bundle branch block. So that's an important point in working up patients with dilative cardiomyopathy. And then Amseln already alluded to, pulmonary artery bending was introduced by my predecessor, Professor Schanz, 12 years ago in Gießen. Interestingly, this was an infant where not the analogy to CCTG8, for example, was thought of, but this was an infant with failing left ventricle, where the plan was with the bending to recruit the right ventricle to work in parallel with the failing left ventricle and to prepare this for a DKS operation. And then the observation was the left ventricle improved with the bending of the right ventricle. And for those interested in all the technical details how this is done, I'd like to refer to a recent review from Dietmar. It's an excellent cookbook, or I should say cook article, if you want to go into the details in order to reproduce this in your institution. So an update on our institutional experiences here. We have treated 45 patients meanwhile. That is 34 patients with restrictive pulmonary artery bending and dilative cardiomyopathy only. And in 11 patients, there was concomitant heart surgery, most likely mitral valve repair or replacement. And the underlying forms of cardiomyopathy are listed here, mostly idiopathic, some non-compactioning, and chronic inflammation response was seen in some at the biopsy. Mean age of patient at treatment was around 1 year, mean weight 7 kilograms. I come back to that in a minute. Follow-up results are given here over the entire period. For all patients, it's survival around 95%. In the group that was treated just with the PA bending, 8 transplants, so that makes a survival free from transplantation of about 70%. And here's an ethical dilemma, because when we went with this approach to the ethics committee, as well as when we talked to the patients, the prerequisite for this treatment is that we are not withholding any form of established therapy. All these children were sent for transplantation, all these children were evaluated for transplantation, and all of them were on the transplant list. And there is a continuous discussion in our team every week when to put off a patient off the transplant list. And you don't want to withhold an established therapy, then there comes an offer and you go for transplantation. And it needs quite some time and a good collaborative team consent. When the function has improved to that point, that you withhold him from getting a transplant. The other point I want to make is that, as always in medicine, success depends on the indication. And so the question is, what is the best patient for this treatment? And the best patient, to our opinion, for this treatment is a young patient, so patient ideally below the age of 3, which has the full recovery potential, not only for hypertrophy, but also for hypoplasia of the heart muscle cells, and it needs to be a patient with preserved RV function. And that's why MRI is so terribly important in the assessment and the follow-up of this patient, because we go for an RV ejective fraction of above 45% to stress this ventricle, that he can be able to respond to the pulmonary artery bending as well. If you have a patient with global dilative cardiomyopathy afflicting as well the right side of the heart, you may end doing worse, putting him on a bend. This is some clinical data on the follow-up improvement in clinical ROS score, decrease in BNP, and improvement in echo parameters over the time. We talked about synchronicity, and that's what Amseln showed from his data in our cohort of patients. We not only have the septal shift, but here, as shown by feature tracking on MRI, improve synchronization between the two ventricles. It's also called the reversible pulmonary artery bending approach, because as the child grows into the bend and the RV becomes under more stress, if the pressure in the right ventricle goes well above 2/3 systemic, the right ventricle starts to dilate, or there is increase in tricuspid insufficiency, it's time to debend. Although we have learned that particularly in the subgroup with non-compactioning cardiomyopathy, it is important to leave some residual bending, because otherwise the function can deteriorate after debending again. There's some summary here, again referring to what Amseln has said, what the working mechanism, the proposed working mechanism is on these children. So if you increase afterload, there is a physiological response of the ventricle to increase contractility. That's called the unwrap effect. And right ventricle has to be well enough to show this effect, and a septal shift improving right ventricular inflow. There is a decrease in left ventricular filling pressure. This is data from a group in Texas that put this up, where they nicely measured intraoperatively left atrial pressure, right atrial pressure, and LV pressure during pulling the band tight. And you can see as tighter they put the bending, the more the left atrial pressure decreases, until it comes to a point when left ventricular pressure goes down, and you clearly want to avoid this, so rather stay in this range for the right bending in the OR. So with better geometry of the left ventricle, less wall tension in the free wall, better perfusion of the myocardium, you can get a better point in the Frank-Starling curve, increasing LV contractility and decreasing mitral insufficiency. Dr. Yerebak Khan, who's now a pediatric cardiac surgeon at Children's National in Washington, when he was working with Hakan Akintürk in Gießen, did an experimental animal work on a toxic cardiomyopathy model. What the Akintürk group did, they used a lamp model with chronic infusion of doxorubicin into the left coronary artery until these animals developed predominantly left-sided cardiomyopathy, and then allocated the animals to either a sham operation or a pulmonary artery bending. Could you start this short video for me that was given to me by Chan? Illustrates this transthoracic echo on the cheap before, the infusion of chemotherapy into the left coronary artery, a long axis and short axis view, not so different from the human echoes. And then after repetitive injections of doxorubicin intracoronary just into the left, you see that there is a reduced function, the synchrony of the septum, and so this sheep then were exposed to pulmonary artery bending in the third step, and this is quite interesting a model because you not only see right ventricular hypertrophy, but you see again a bit of a septal shift. There is still the synchrony, but it's better than before. And using this model, he could also show that compared to sham-operated animals in blue, there is a reduction in left ventricular size and an increase in left ventricular function in this toxic model of cardiomyopathy. And just one more experimental study to elucidate the effects of pulmonary artery bending. In this is shown here. Dr. Grosse-Kreinburg from our clinic did an experimental study in mouse model together with the Max Planck Institute of Heart and Lung Research at Bad Nauheim, where the bended mice induced a septal shift after bending. Again, this was controlled against the sham operation, and then you could see the effect with right ventricular hypertrophy and the septal shift in a 9 Tesla MRI scanner. And without going into too much details, the interesting point from my perspective here is that you see an increase in genes, this is X-fold to baseline, that are involved in hypertrophy, but not only in the right ventricle, but also on the left ventricular side. So if you take tissue from the free left ventricular wall, you also get an increase in these genes, upregulated and downregulated, albeit not to the same extent as in the right ventricle. Finally, I like to round off with an example of ischemic cardiomyopathy. This was a neonate transferred to us after presumed myocardial infarction. It's a poorly contracting left ventricle. The aortic insufficiency is here artificially induced by the catheter, but nonetheless you get an impression of the function. In MRI, we saw a thrombus in the left atrium. I want to discuss whether this is the source or the consequence of the poor function. And what else you can appreciate is that the posterior wall of the left ventricle is not working at all. In late enhancement, you see that there is here this white line in the posterior wall, and this child we took in the cath lab, did the whole study including biopsies, and at the same time did neonatal cell therapy. As you may have known, we have a program for intracoronary cell therapy in some of these children. And this was done here as well with a good response, not only a decrease in BNP afterwards, but an improvement in function, not normal, but better, and the child is off transplant list by now. Our experience with that is limited, just 14 patients. You have to understand that this is a new therapy that is not only off-label, but it's also off-reimbursement. So all this is financed by the research fund of our clinic. And 7 of these patients were with dilative cardiomyopathy. We could show that it's technically feasible also in the youngest child, as I showed you, the infant where the right coronary artery and the first marginal branch was targeted. And it's safe. We didn't see side effects so far. And we believe that it holds the potential just as an add-on therapy to standardized therapy to improve in selective patients. Of course, larger scale studies are underway. both in the US and Japan, where randomized double-blind trials are either planned or actively recruiting by now. So, in summary, I'd like to present our institutional flowchart for children with primary cardiomyopathies. After medical stabilization or under standard medical therapy, which in Gießen is a beta blocker, beta-1 selective beta blocker, ACE inhibitor, and aldosterone. You should consider restrictive ASD, especially in those patients with ongoing pulmonary congestion and symptoms for that, or those who are not able to be weaned off of chronic diuretic use. You have, of course, to check for electrical dyssynchrony and can go for resynchronization therapy in a subgroup of these patients. In those with a relatively well-preserved RV function and in young children that have full regeneration potential, we offer them our pulmonary artery bending approach and a localized dysfunction, especially in children with ischemic cardiomyopathy, may be targeted by cell therapy, which again relies on the higher regeneration potential that children may have compared to adults. And with that, I thank you for your attention.
Well, thank you, Christian. It's an excellent talk. I think there's questions from the audience? No? So I have one question. I was wondering if you do the band. I understand that you do that only in smaller kids, so they tend to grow, and then the band becomes more restrictive. So what's your ideal restriction? What's your ideal gradient over that band? And when would you decide to do the ballooning? And the second question, to which grade should you reduce the band? So what is the perfect band for the failing left ventricle?
Yeah, as you already implied yourself in the question, the ideal patient is the one that's young and has preserved RV function. Nonetheless, even in this population, the normal course after pulmonary artery bending is in the first couple of days, they do worse. They have a reduced function. They are much more prone to infections, for example, than before. And then after that, it takes some time to improve. And that's logical if you think that genes are switched on, they need to produce protein and so on and so forth, so that takes time. In the OR, the general aim is to reduce the pulmonary valve circumference by roughly 50%. But that needs to be modified on an individual basis, looking at the septal shift. If you get that earlier, you start earlier, not pulling it too tight. If you, and we measure with a direct pressure line, left atrial pressure, we observe blood pressure, and we don't want to see that systemic blood pressure drops more than 10 or 15%. Central venous pressure should not increase over 10 millimeters of mercury in the ideal setting. So, as you said, these are young children, and we rather go off the OR in anesthesia with a gradient of 20-25 millimeters of mercury. And then when a child is awake, recovers, and grows, this will rise. And with regard to the reversing of the bending, as I said earlier, general rule of thumb is if the estimated RV pressure is well above 2/3 systemic, or if there is dilation of the right ventricle, if there is new or increasing tricuspid insufficiency, we go in for debending. And we do that with high-pressure balloons in a gradual way so that we can stop at certain intervals and remeasure. We know that patients with non-compaction in cardiomyopathy, we rather leave 40 to 50% RV pressure. We need some residual bending because initially this was taken fully away and these children deteriorated again. And in others, over the years, we go back and then redilate, and many of the older patients, they are now fully free of bending, and if they stay stable.
We have a question from audience. Please, Professor Beber.
Philipp Berber from Hanover. Christian, thanks for a wonderful talk. Thank you very much. I'm just curious about your experience on patients who sort of live between the worlds. They start with myocarditis as an infant, and then myocarditis sort of heals to some degree, which we all know may take some time. You prove with biopsy that it's no more really active. Mm-hmm. The patient cannot be weaned from ICU support. When do you start thinking about a ban in these patients, or don't you at all?
No, that's a good question. And actually, we included a number of patients with what I termed chronic, whatever that is, myocarditis. So we certainly would stay away from acute myocarditis. If you see fulminant inflammatory cells in the biopsy or in the MRI, then this is not the right patient, because this patient is acutely ill and needs to recover, and some of them recover on their own, as you said. But if in the course of the disease we see no spontaneous recovery with supporting medication, we consider this patient and given the circumstance that the right ventricle is better preserved than the left, we consider these patients as candidates for pulmonary artery bending.
So how do you actually manage them? You know, we've got a few patients of these in the recent times. We've been discussing hotly in the group when to offload the left atrium and when to put them on a band. Actually, we had one patient, an infant with a history, I just sort of summarized briefly, which then eventually, having discussed this with Dietmar, received a band. And he was advising us precisely how to do that, so I think we did it properly. We had a beautiful response. So 2 weeks of, ventricle came down from 32 to 25 millimeters, injection fraction improved, patient improved. After 2.5 weeks of medication, on oral medication as advised, the patient had a full breakdown, needed acute ECMO, was put on on Meadow system, and finally transplanted. Mm-hmm. So that's the reason why we keep struggling with these patients. It's just not huge numbers. But I was just wondering if you had maybe more experience on how to manage these borderline cases.
I cannot comment on your individual patients because I don't have the details, but obviously, these patients need to stay under close observation, and especially early after the bending. And as you said, if the patient improved, there is some response, and then I don't know what the second hit is that made him worse again. But no questions, especially in the early phase after pulmonary artery bending, they need to be under close observation. And then I like to see them at least every second time in our institution, even though we trust referring physicians elsewhere, because I think you have to have a very thoughtful follow-up on them.
Thank you. I think we have to move on because time